President.
Mr. President.
Mr. President.
Mr. President. You know, before you go, Max, I just want to ask whether it's you, Tom, or anybody else on the Republican side, and maybe some of the House members might be interested. You know, Senator Coburn mentioned some cost containment issues where it sounds like we agree. Fraud and abuse, we agree. It sounds like you have maybe one other idea that you don't think is in our proposal, but the idea of undercover patients, but that's something that I'd be very interested in exploring. I don't think conceptually that would be a problem. The issue of prevention, and that includes, by the way, things like how our kids are eating and getting exercise, and I'm proud of the First Lady for working to see what she can do on that front, and there are some provisions in the legislation that's already been passed through the Senate and the House that directly relate to this that I think you'd be supportive of. The issue of defensive medicine, as I indicated, Secretary Sebelius is working on this, but I think that there are things that we could do at the state level to help foster innovation and eliminate some of the concerns that you've got. I would be interested in hearing from any of our Republican colleagues what objections they have to what we consider one of the biggest ways of driving down costs, and that's what Steny just referred to, which is allowing individuals and small businesses who are currently trapped in a very expensive market. Essentially, they're having to be out there fending for themselves, to be able to buy into essentially a large group, to become part of a large group, just like all of us as government employees are part of a large group, so that they have more negotiating power with the insurance companies, which I think we all agree would drive down costs. You know, if you've got some bigger purchasing power, insurance companies want more customers, they would drive down those costs. I know some of you have agreed to this as a concept in the past, and so my question is there something in terms of the way the House and Senate bills have been structured that leads you to be concerned or want to not move forward on that approach? John?
Well, Mr. President, I'd like to yield to Mr. Klein from Minnesota, who will talk about the small business health plans in terms of how we would propose to do this.
Thank you, Leader. Thank you, Mr. President. I think that Senator Alexander framed our overall position very well when he said that we're looking at thousands of pages of legislation, and we believe a better approach is to go step by step to address these issues of cost. We certainly agree that you get better economies of scale if you can come together. We have proposed in both the House and the Senate, in fact, for a number of years, that small businesses be able to band together in small business health plans or association health plans. We all know, and I've heard everybody say here, that small businesses are the engine that drives our economy. We also know that about half of the uninsured either work for small businesses or depend upon somebody who does. And so we believe that we ought to address that issue by allowing these small businesses to band together in the same way that I think, Mr. President, you mentioned, large companies do. And I mean really the same way. So that they get all the advantages of, if they self-insure, being able to avoid the 50 state mandates, being able to lower their administrative costs because they're not having to deal with that. And it will lower the cost of premiums for these small businesses and allow them to insure more people and to keep people, they're already insured, on the books, because we all know stories like we've heard here of small businesses that are saying, I can no longer provide insurance for my employees. Yeah. Small businesses have been asking for this for years. It's not a new idea.
Right.
They've been asking for it for years, and we think it's a far better way to get these economies of scale than the exchange thing that's in the huge bill. That this will actually allow businesses to be able to lower their costs exactly the same way that large businesses do.
Okay. Max is going to go, and then I'll go to you, Rob. Max, do you want to address this issue of how we can allow people to buy into large groups, how the Senate bill accomplishes it, and I don't know if you
Sure.
want to remark on what John just said.
Yeah, well, absolutely. I'd go first like to say something that just strikes me just in spades. Frankly, we all studied this issue a lot, health care reform. We basically know what the problems are, all of us. We basically know the need, the current system is unsustainable. We are actually quite close. There's not a lot of difference. Close in the sense, without being corny and dramatic about this, that the American people want us to do something that's just basically reasonable. Doesn't have to be one congressman, one senator's provision, but basically reasonable. We are on the verge and the cusp with not too much effort to try to bridge a lot of gaps here, because the gaps, in my judgment, are not that great. Let's take the list, for example, that Lamar mentioned. As you said, Mr. President, we are basically including most of those provisions, if not all, in our joint legislation. Selling insurance across state lines, for example. We allow for that, not exactly in the way that some would, but sure, with compacts, and once state exchanges are up, people will be able to buy and sell insurance across state lines and achieve that competition. In addition, you mentioned lawsuits. Secretary Sebelius is working to try and find ways to encourage states to settle, resolve issues before they become big bad lawsuits. Add to that, Lamar says we should find ways for states to be able to lower their costs, so we do that. We let states opt out. They can do what they want to do. And Senator Wyden also has a proposal. Senator Cantwell has a proposal. We give a lot of flexibility in that regard. Expand HSAs, that's fine. There's nothing wrong with HSAs, but we also have to have products for poorer people, lower income people. HSAs work pretty well if you have middle or high income. Pre-existing conditions, clearly, we all agree on that. We have those provisions in our bill. Respect to small business, we're not that far apart. Some suggest association health plans, where small business people can band together in an association pool and get better insurance. That's fine. What we provide for in our legislation is something similar. It's called the SHOP Act. Various senators, bipartisan, have worked on this, and basically it allows sets up a small business arrangement in exchanges. Small business participates in their own exchange and gets the advantage of all the pooling, and then they can do what federal employees do today. They can shop and compare and to get the best deal. And I would guess that most small businessmen would like to do that. I might add that we're also providing tax incentives, tax credits for businesses, small business, that wants to purchase health insurance for its employees. And it's pretty good. It's 35% tax credit first couple of years. Then once the exchange is up, it's 50%. So the main point is we're not really that far apart. We're trying to find ways for small business to pool, small business to take advantage of competition, to shop and compare. Also some tax provisions that to encourage businesses to get health insurance. So I might say too that if you look at all the provisions that Stanley outlined, many of them, we agree on prevention. There are major prevention provisions in our legislation, as Senator Coburn mentioned. We also agree on trying to change the way we reimburse docs. I think the biggest game changer here, frankly, is how we reimburse our doctors. They're based more on quality rather than quantity. I know Tom Coburn really agrees with that as a doctor. And most doctors do. And it's another example we really are close. And I think that once we keep pushing on those areas where we're close, it's going to make a difference. The exchanges, as you mentioned, Mr. President, it's a Republican idea. It works. What I like about exchange, it's like Orbitz. It's like Expedia. You know, you go to Orbitz or Expedia to buy an airline ticket, you compare it, get the best price. That's basically what this is. It's an exchange. You go to the exchange, you shop around, and you get your best price. That's going to help, in my judgment. I also think that we should, where the hospitals should publish
the cost of their basic procedures, whether it's appendectomy or colonoscopy or whatnot, to enable consumers to shop around. Where's the best price? We all know that there's a wide disparity in what hospitals charge for the same procedures. Let's, I think disinfectant of sunshine helps. It helps consumers. It helps our people. And fraud and waste, we've talked about that. We have major provisions in our bill to fraud and waste. Mr. President, I compliment you because in your proposal you go even farther.
We took some additional ideas from folks like Congressman Ross.
They're great ideas, and we address the unnecessary readmission rates, hospitals, et cetera. The main point is we basically agree. There's not a lot of difference here, and I just like us to kind of just, there's an opportunity for us to work out some of these differences.
Mitch, is there somebody?
Yeah, Mr. President, I'm going to yield to John here.
John?
I'd like to yield to Dave Camp to continue this conversation about cost containment.
Dave?
Thank you, Leader Boehner. Thank you, Leader Boehner, and thank you, Mr. President, for the invitation today. I think as we focus this part of the conversation on cost, a lot of Americans say to me, if you're really interested in controlling costs, well, maybe you shouldn't be spending $1 trillion on health care, as the Senate and House bills do. Also, cutting Medicare benefits by $500 billion to fund this new entitlement is, I think, a step in the wrong direction, and many Americans do as well. The nonpartisan actuaries at the Center for Medicare and Medicaid Services say on page 4 of their letter on the Senate-passed bill that it would bend the cost curve in the wrong direction by about $250 billion. They specifically say the health expenditures under the Senate bill would increase by $222 billion. A key way of reducing costs that's missing from the House and Senate bills is responsible lawsuit reform that guarantees injured parties, much like our two largest states have adopted, Texas and California, access to all economic damages, such as future medical care. If they need nursing care in the future, they'll get it. Lost wages, reasonable awards for punitive damages and pain and suffering. On page 4 of its letter to Senator Hatch, CBO found that this common sense reform would reduce the federal deficit by more than $50 billion. Now that's just on the government side, because as we know, CBO doesn't score the private side on this. And PricewaterhouseCoopers has done a study that said savings could be as high as $239 billion if this reform were adopted. There are two features in the House and Senate bills that move in the wrong direction. Both bills feature restrictions on health spending accounts where people can save tax-free for their health care, as well as FSAs, flexible spending accounts. These changes are such as they ban the use of over-the-counter medication out of both of these plans. There's a new cap on FSA contributions of $2,500. That text, that language is found on page 1,959 of the Senate bill. And that will hinder the growth of those plans, and which encourage Americans to consider quality and price when they purchase health care. And let me just say, under HSA plans, premiums increased just 1.3% for individuals in 2007 to 2008 and declined 5.4% for families in that same period. And when people switch from a PPO, a preferred provider organization, to a health savings account, their premiums decline by an average of $3,800. Now, another concern I have is the Senate bill, which on page 982 creates an unelected board charged with recommending even more Medicare reductions. And if Congress doesn't accept these recommendations, they have to find other Medicare spending to cut instead. And that gives, I think, too much authority to unelected bureaucrats rather than to elected representatives of the people, and the power to decide whether to cut Medicare and by how much. Now, holding down health care costs for the government is important, but I think it's also important to hold down costs for families and employees.
Dave, I don't mean to interrupt, but we're going to have the whole section talking about deficits, and we can talk about the changes in Medicare. We were trying to focus on costs related to lowering families. And the only concern I've got is, look, if every speaker, at least on one side, is going through every provision and saying what they don't like, it's going to be hard for us to see if we can arrive at some agreements on things that we all agree on. So I don't want to try to cut you off. Please finish up, but I just want to kind of point out that
I do want to say on this issue on premiums, CBO in their letter on page 4 does say that the estimated average premium per person for non-group policies would increase by 10 to 13%.
This is the discussion that I just had about Lamar.
Yes,
and
they do say that, and they do say that the value of the benefit is higher, and that is why it goes up. But
Right.
the reason the value of the benefit is higher is because of the mandates contained in the legislation. And this is one of our big concerns with a lot of the issues that have been raised. Yes, we have similarities, but when all of this is structured around a government-centered exchange that sets the standard for these policies, states can't get out of these requirements unless they seek a waiver from the Secretary. That kind of approach raises costs, and so both of your comments were correct that costs do go up, and it's because they have a richer benefit, but the reason it's richer is because of the mandates contained in these very large bills.
Okay, I'm going to let Rob, feel free to respond to anything that Dave indicated or to any of the other issues that have been discussed.
Thank you, Mr. President. I want to thank my friend Tom Coburn and John Klein for the spirit of conversation which they offered and try to carry that forward a little bit. The President asked at the beginning of this, what ideas do we share about cutting costs? And Tom, I think you had some very good ones. Fraud, that the President has a proposal that says we should have a database. If you've committed fraud against Medicare once, you can't make a contract again. Wellness, there's a lot of good ideas in the bills. Junk lawsuits, I think that there's what Secretary Sebelius is doing is very important in curtailing that. And then the President asked the question about whether we can find agreement on pooling the purchasing power of small businesses and individuals so they can get the same deal that big companies and members of Congress get. And my friend John Klein talked about the Association Health Plan proposal. Respectfully, John, I think that what you're talking about with association health plans and what we're talking about with exchanges is a semantic difference. It's a matter of pooling the purchasing power of small businesses and individuals to get a better deal. But there is one substantive difference that I want to ask about because we are concerned about it. If we can resolve this, I think we could agree. Let's take the case of a woman who has a baby by C-section. And she lives in one of the many states that say you can't be kicked out of the hospital after you've had a C-section until your doctor thinks it's time for you and the baby to go home. Now, under the Association Health Plan proposal, that rule wouldn't apply to that lady and her baby, that there would be no protection of her in that situation. We think, John, that there shouldn't be necessarily, 51 different rules for each state, but there ought to be some minimum federal standards in these exchanges to protect people in cases like that. So I think the issue is if we could find a way to agree that in a case like this where, a lady has a baby by C-section and has the ability to not have the insurance company get between her and her doctor, so the doctor makes a decision about when they go home, we could figure this out. And how do you feel about that?
If I could just respond to that, my friend knows very well that there are large companies today who operate under what I'm proposing for association health plans. They get a waiver. They don't have to comply with the individual mandates of all 50 states. And I don't hear people complaining about the insurance policies that they're getting from their big companies. In fact,
we do.
Many of those now would fall into what we've been calling Cadillac plans because they provide very excellent service. So I think that, frankly, is a red herring. And I think that you're not going to have adequate coverage if you have an association health plan that's working under the same rules as a large company.
But John, would you favor a standard that says they have to do something like that, or would we just leave it up to the insurance company?
I would say that we put the association health plans in exactly the same position that large companies are today, with exactly the same rules under ERISA.
See, we don't, with all respect, we don't agree with that. We don't agree with the idea that the insurance company should get to make that kind of decision about whether the lady goes home Thursday or Sunday. Now, I don't think that's intrusive. I think that makes common sense. But if we could find a way to bridge that gap, and I think we could, then I think the AHPs that you support aren't all that different than the exchanges that we do, and I would think that would be a common ground.
The This has been a useful conversation. Paul Ryan wants to make
Mr.
a
President,
comment.
can I just interject one quick point here, very quick, just in terms of trying to keep everything fair, which I know you want to do. To this point, the Republicans have used 24 minutes, the Democrats 52 minutes. Let's try to have as much balance as we can.
I think the Republican leaders are controlling the time for the Republicans, if I'm not mistaken. Is that right?
I don't think that's quite right, but I'm just going back and forth here, Mitch. I think we're just trying to go back and forth, but that's okay. Paul, I was about to call on you, if that's all right. Go ahead.
All right, here, Rob, here's basically what we're looking at. The difference is this. We don't think all the answers lie in Washington regulating all of this. So the problem with the approach we're seeing that you're offering, which I do believe, Senator, is very different than what we're saying, is we don't want to sit in Washington and mandate all of these things. So what you're doing is you're defining exactly what kind of health insurance people can have. You're mandating them to buy this kind of health insurance. And so we simply say, look, if the National Restaurant Association or the National Federation of Independent Business, on behalf of their members, wants to set up an association health plan, we think they'll probably do a good job on behalf of their members. Let them decide to do that instead of restricting insurance competition by federalizing the regulation of insurance and by mandating exactly how it will work. You make it more expensive and you reduce the competition among insurers for people's business. We want to decentralize the system, give more power to small businesses, more power to individuals, and make insurers compete more. But if you federalize it, standardize it, and mandate it, you do not achieve that. And that's the big difference we have.
Paul, would you yield? Mr. President, may I ask him to yield?
We're not in a formal hearing here, okay. So go ahead.
Paul, I read your roadmap, and I thought one of the things that you said is that there should be some minimum consumer protections in the exchanges that you proposed. Did I get that wrong?
And there are in every state. And so what we're simply saying is, look, lots of us have offered lots of different ideas. We've got dozens of Republican ideas offered in the House, in bills, in the Senate. And many of us look at the point of the fact that the states, you know, do we distrust our governors? Do we distrust our state legislatures? Do we distrust all the state insurance? Yeah, okay, some of you may do that.
Depends on who it is.
But should we regulate all of this? Should people in Washington decide exactly how this works and what you can and cannot buy?
Paul,
well, there's just a difference in philosophy.
No. Look, I think this is an important point. We've got a couple other people who want to speak. We've gone about 45 minutes on this section. We're running over because we went long on the opening statements, and you're right. There was an imbalance on the opening statements because I'm the president, and so I made. I didn't count my time in terms of dividing it evenly. In this section, Mitch, we've gone back and forth pretty well. I know Senator Schumer wants to speak, and I know that Jim Clyburn wants to say something very quickly, and may want to.
John Kyle would like to.
And John, but what I want to do though is just focus in on this philosophical debate. This is a legitimate debate, and it actually speaks to the point that Congressman Camp was making earlier about what's happening in the exchanges. You know, when I was young, just got out of college, I had to buy auto insurance. I had a beat-up old car, and I won't name the name of the insurance company, but there was a company. Let's call it Acme Insurance in Illinois, and I was paying my premiums every month. After about 6 months, I got rear-ended, and I called up Acme and said, you know, I'd like to see if I can get my car repaired, and they laughed at me over the phone because really this was set up not to actually provide insurance. What it was set up was to meet the legal requirements, but it really wasn't serious insurance. Now, it's one thing if you got an old beat-up car that you can't get fixed. It's another thing if your kid is sick or you've got breast cancer. So the general idea has been here that we should set up some minimum standards within the exchange, that a plan that people are buying into, whether it's a small business or an individual, should be at least solid enough that if your kid got sick, they're actually going to be treated. That if something happened, that you weren't left with a huge bunch of out-of-pocket costs. It is true that you can always get cheaper insurance if it has really high deductibles or really high co-payments or doesn't cover as many things. And so there has to be a balance that's struck there. I just want to point out, though, that the principle of pooling is at the center of both the Senate and the House bill. And the reason I'm pointing this out is because there was a lot of talk about government takeover of health care. And the implication, I think, was that everybody was going to have to sign up for a government health care plan. Now, that's not the issue. What the issue here, which we've had an honest disagreement about, is how much should government set a baseline versus just letting people decide that, you know, I can't really get decent insurance, but, you know, maybe this is better than nothing. And that's a legitimate argument. I don't disagree with that, but I just wanted to point out that when we start talking about how much government involvement is at issue here, it's not because the House or the Senate bills are a government takeover of health care. It is that the House and the Senate bills put in place some regulations that restrict how insurance companies operate, and if there's an exchange or a pool that's set up, that there's a baseline sort of minimum requirements that were expected, and I understand that there may be some philosophical differences on the other side of the aisle about that issue. Chuck, go ahead.
Thank you, Mr. President, and I thank you. I think this has been a constructive dialogue. I was glad to hear my friend Tom Coburn's remarks. I think we agree with most of them, and particularly the point that about a third of all of the spending that's done in Medicare and Medicaid, I would imagine a lot of it's in the private sector as well, doesn't go to really good health care, goes to other things. And the real nub of this is how do we wring that waste out, that fraud, abuse, duplication, without interfering with the good care that we want every person on Medicare, Medicaid, and private insurance to get. The average citizen knows this happens. How many times when you look at your medical bill, you've undergone a minor procedure, and you see Dr. Smith, $4,000, and you sort of vaguely remember he just waved and poked his head in the door? Or how about, probably it's happening right now, there's some salesman talking to some doctor and saying, hey, my company will finance a machine for you for $1 million. So you don't have to pay for it. You can gradually pay it. We'll show you how to fill it up all the time, and you'll increase your income by $200,000. And there's another machine 3 blocks away that's already working and available. So these are the things we have to go after. And Tom, I thought your suggestion of undercover patients, and I tried to check here, I don't think we do it now, is a great idea. And it's one that we can come together on. I think there are other things that we can come together on. Senator Cantwell put a provision in the Senate bill that said we ought to reward doctors for doing quality, not quantity. So that doctor, and there's a small number of doctors that Gawande study showed, thing in the New Yorker that I think we've all read, that a small number of people who are just trying to maximize their income throw the whole system off. It threw the whole city of McAllen, Texas off, while El Paso had much lower rates. Maria Cantwell has a provision in there which I would think you folks could agree on, that says that we ought to reward doctors for the quality, not the quantity, not the number of times they could put someone through a machine, but how good the care is. There's a provision in there, Senator Rockefeller authored, it comes in the insurance part, that says 80 to 85% of what insurance companies put forward should go to the get money in for, should go to the patient. So I think we can do all of these things, but if we're going to eliminate the waste, fraud, and abuse in Medicare, it does mean we're going to cut some of that out. And when I hear my friend Dave Camp say you cannot cut money out of Medicare, well, we don't want to cut the good stuff that you point out, or add the prevention. But if we're going to, if 1/3, if what Senator Coburn says, that 1/3 of Medicare doesn't go to patient care, You can't just get up there and say, we don't want to cut anything out of Medicare. We want to cut the bad stuff and keep the good stuff. And I think that's where we can find common ground on some of the things you've mentioned, some of the things that are in our bill. And I hope at least in this area we can move forward that way, because frankly, the Republican Party has always stood for getting rid of the waste, fraud, and abuse in the system. In '97, it was the centerpiece of your program, and all of a sudden this year we're hearing, don't do any of that. That's something that I think we can come together on. I thank you.
Mr. President, can we turn to John? I'm sorry.
Sure. I'm sorry. You had John. We're going to go to John, and then we're going to go to Jim Clyburn, and then I think we're going to take a break because we've run out of time. So, John.
Thank you, Mr. President. I think you framed the issue very well just a moment ago, because there are some fundamental differences between us here that we cannot paper over. And, Mr. President, when you said that this is a philosophical debate and it's a legitimate debate, I agree with that. We do not agree about the fundamental question of who should be mostly in charge. And you identified this question as central. Do you trust the states or do you trust Washington? Do you trust patients and doctors making the decision, or do you trust Washington? Now, there's a mix of both, of course, in health care. But there is a big difference between our approaches. And there is so much in the bills that you've supported that puts control in Washington that we have a very difficult time supporting those provisions. And it's not a matter of just saying we all agree on the goal of reducing waste, fraud, and abuse. We all do, of course. It's how you do it. Now, let me give you a couple of examples. Dave Camp, I think, pointed out the answer to the dispute that you and Lamar Alexander had a moment ago, and he was exactly right. Let me quote from the Congressional Budget Office letter. This is from Doug Elmendorf to Evan Bayh, November 30th, 2009. Quote, CBO and Joint Tax Committee estimate that the average premium per person covered, including dependents, for new non-group policies would be about 10% to 13% higher in 2016 than the average premium for non-group coverage in the same year under current law. Oliver Wyman, a very respected third-party group, says it's even more, about 54%. In my state of Arizona, 72% increase. Why is it so? For a variety of reasons, but one of which both you and Dave Camp agreed on. It is a richer benefit. How did it get that way? Because the federal government would mandate it under your legislation in the insurance exchanges. And as a result, there would be a higher cost. How does this happen? There is an actuarial requirement of 60% actuarial value in the exchange for the least costly plan. But the average in the country today of a high deductible plan is 48%. The range today is 40 to 80%, and the average is between 55 and 60. So what the government is doing here is saying, we're going to mandate that the insurance cover more things than it does right now, and therefore the cost is going to go up. Second example, you say, how can we help small businesses? Well, we know one way you don't help small businesses is by raising the payroll, the Medicare payroll tax on them, which is what this legislation does. Besides that, it's a job killer. Look at the taxes on beneficiaries as well. This is a third example. You don't cut costs when you raise taxes on medical devices that help us, when you raise taxes on pharmaceutical products, when you raise taxes on the insurance premiums themselves. Quote, these fees on insurers, medical devices, and pharmaceuticals would increase costs for the affected firms, which would be passed on to purchasers and would ultimately raise insurance premiums by a corresponding amount. Congressional Budget Office. So when you raise these taxes in all of the different fees that are in this legislation, it inevitably increases the costs on the consumer. And why do you have to raise all of this money? Because of the expenses of the legislation that underlie all of this. That's why Republicans would rather start not by having to raise a lot of money in order to pay the high cost of this bill, but to start a piece at a time directing solutions to specific problems. That way you don't incur all of the costs up front, which require you to raise the taxes. Last quick point. One of the worst things about this is for people that have catastrophic medical expenses today, after you've spent 7.5% of your adjusted gross income, you can deduct that. This bill would raise that to 10%. Who does that hurt? The very people you promised, Mr. President, that you wouldn't allow taxes to be raised on. Average age, 45. Average income, $69,000. These are not wealthy people. Just another example of why, because the bill has to raise so much money, it ends up hurting the very people that we want to help.
Okay. John, I'm going to go to you, Jim, but since, as has tended to happen here, we end up talking about criticisms of the existing bill as opposed to where we might find agreement. I feel obliged just to go through a couple of the points that you raised. Just to go back to the original argument that Lamar and I had, and we've now chased around for quite some time. Look, if I'm a self-employed person who right now can't get coverage or can only buy the equivalent of Acme insurance that I had for my car. So I have some sort of high deductible plan. It's basically not health insurance, it's house insurance. I'm buying that to protect me from some catastrophic situation. Otherwise, I'm just paying out of pocket. I don't go to the doctor, I don't get preventive care. There are a whole bunch of things I just do without. But if I get hit by a truck, maybe I don't go bankrupt. All right, so that's what I'm purchasing right now. What the Congressional Budget Office is saying is that if I now have the opportunity to actually buy a decent package inside the exchange that costs me about 10 to 13% more, but is actually real insurance, then there are going to be a bunch of people who take advantage of that. So yes, I'm paying 10 to 13% more because instead of buying an apple, I'm getting an orange. They're two different things. Now, you still have an option. Let me finish. The way that this bill is structured uses a high-cost pool, a catastrophic pool, for people who can't afford to buy that better insurance. But overall, for a basic package, which, by the way, is a lot less generous than we give ourselves in Congress. So, I'm amused when people say, let people have this not-so-good plan, let them have a high deductible, but there'd be a riot in Congress if we suddenly said, let's have Congress have a high deductible plan, because we all think it's pretty important to provide coverage for our families. And the federal health insurance program has a minimum benefit that all of us take advantage of. And I haven't seen any Republicans or Democrats in Congress suddenly say, you know what, we should have more choices and not have to have this minimum benefit. So what we're basically saying is we're going to do the same thing for these other folks that we do for ourselves. On the taxpayer's dime, by the way. Now, there is a legitimate philosophical difference around that, but I think it's just very important for us to remember that saying there's a baseline of coverage that people should be able to get if they're participating in this big pool is not some radical idea. And it's an idea that a lot of states, we were talking earlier about what states do. A lot of states already do it. This, by the way, goes to the other difference that we have when it comes to interstate purchase of insurance. Actually, this is a Republican idea, been championed by the Republicans. We actually agree with the idea that maybe if you get more regional markets and national markets as opposed to just state-by-state markets, you might get more choice and competition. People would be able to say, gosh, there's a great insurance company in Nevada, and I live in New York, and maybe I can purchase it. That's actually something that we find attractive. So do you guys. But again, the one difference, as I understand it, and the reason you're not supporting the approach that we take, is what we say is there should be sort of a minimum baseline benefit, because if not, what ends up happening is you can have a company set up in Nevada. Let's assume there were no rules there. There are no protections for the woman who's got breast cancer. They go into New York. They offer pretty cheap insurance to everybody who's healthy. They don't offer the same insurance to people who aren't so healthy. They drain from New York all the healthy people who are getting cheaper rates, but now suddenly everybody left in New York who doesn't qualify for that cheaper plan is in a pool that's sicker, older, and their premiums go up. So what we've said is, well, if we can set a baseline, then you can have interstate competition, but it's not a race to the bottom. Rather, everybody's got some basic care. Now, these are legitimate arguments to have, but I just want to point out that this issue of government regulation, and which we're going to also be talking about with respect to insurance, is very different than the way this has been framed during the course of the debate over the last year, which is government takeover of insurance. This is not a government takeover of insurance. What it is saying, let's set up some baselines and then use market principles, the private sector, and pooling in order to make sure that people get a better deal. So, Jim, and then what we're going to do is we're just going to move on to the next topic, but anybody who wants to pick up on what we've just talked about obviously can return to that as well.
Thank you very much, Mr. President. Mr. President, leaders and members of the Congress. Look, there are two cost containment issues that I think have not been sufficiently vetted here today. Let me set this up by sharing with you a conversation I had on yesterday with the administrators of the Dillon or McLeod Healthcare Center in Dillon, South Carolina, a little town, Mr. President, you've become quite familiar with. They told me that their emergency room activities have doubled over the past several years. And they were looking for some assistance to expand the size of that emergency room. When I began to question them as to why in this small county, not in my district, they had had such a doubling, what it turns out is that they told me that 31% of the people that they treat in that emergency room are not there for emergencies. They are there for primary care. Now, they said to me that some of these people do not have health insurance, but many of them do have health insurance, but they cannot afford the $1,500 to $2,000 if they were to go to a private primary care provider. So they are now treating people who've got employer-based health care that they cannot use. They're holding that for some catastrophic event, but they need some assistance. Now, I think that no matter what kind of plan we develop, there will be many people left uncovered, and we need a safety net for those people. I believe that the one way to provide that safety net and to take care of all of those people who may be uncovered and those people who have $2,000 deductibles with primary care is for a significant expansion of community health centers. And we have not spoken about that here today, but I know that your proposals, Mr. President, I know that both the House and Senate plans have that in them, and I do believe that that is very, very important. We have more than a 40-year experience with these healthcare centers, and I do believe that no matter what we do, there ought to be a significant expansion of those healthcare centers. Secondly, Mr. President, a lot of other things have been said about what I have on this paper, but one other thing I would like to mention, and it has to do with people who really cannot navigate the system. People who work very hard, they know what they need for themselves, but I was reminded of that when we talked about putting together restaurant owners who will design plans for their members. I would hope that when we started designing plans for the members of small businesses, let's keep in mind that the employees of those small businesses are not negotiating these plans. They are at the mercy of the the small business owners. And the question is whether or not the plans are sufficient that they will not fall into the same category that these people with $1,500 to $2,000 deductibles. Finally, Mr. President, this morning I was doing one of these call-in shows on C-SPAN. A gentleman called in, and he was very, very emotional. He said to me that he was getting ready to have transplant surgery. But he was told by the hospital that because he's on Medicare, that his post-operative treatment is going to be limited to 3 years. After that, he'll have to find some way to pay. This man was very emotional today. What we're doing here fixes that, and I do believe that we ought to really be honest with the American people. When we talk about what we are doing with Medicare, we're trying to make sure that Medicare is there for that man and so many others who will find themselves in this position. With that, I'll yield back, Mr. President.
Okay, I think this has actually been a very useful conversation. What I'm going to do is move on to the next topic, but maybe after we break for lunch and come back, I want to go through some areas where we decided we agreed. I know the abuse is a good example. Some areas where we still disagree. One thing, John, you shook your head when I said that people would be able to choose the better plan because the notion was, well, people are mandated. Actually, any insurance that you currently have would be grandfathered in so you could keep. And so you could decide not to get in the exchange the better plan. I could keep my Acme insurance, just a high deductible catastrophic plan. I would not be required to get the better one. If I chose to get the better one, it would be 14 to 20% cheaper than if I were going into the individual market. I just want to clarify that issue.
Well, Mr. President, if I could clarify, that's for a very limited period of time, number one. Secondly, the incentives are set up so that employers would drop you from their coverage because it's cheaper for them to pay the fine than to continue to pay the insurance, so they wouldn't be able to keep what they have. And third, there are still mandates in the legislation as to what you can do with what you have, such that it doesn't end up being the same coverage. So with all due respect, I disagree. And it's just a fundamental disagreement between us. Does Washington know best about the coverage people should have, or should people have that choice themselves? Pay a little less, get a little less coverage, or pay a little more and get more coverage?
Can I just say that at this point, anytime the question is phrased as, does Washington know better, I think we're kind of tipping the scales a little bit there, since we all know that everybody is angry at Washington right now. I think so it's a good way of framing. It's a good talking point, but it doesn't actually answer the underlying question, which is, do we want to make sure that people have a baseline of protection? And this topic of the insurance market reforms